Hello, everyone, and welcome to our final session of the Pediatric Dentistry webinar series. My name is Omar, and I am the webinar director at the SCORE committee. It's a pleasure to have you all with us today. Before we begin, I would like to introduce the International Association of Dental Students, IADS, a global organization that connects dental students worldwide and promotes academic exchange, professional development, and international collaboration. This webinar series is organized under the SCORE Office of IADS, the Standing Committee on Research and Education, which focuses on research, education, and global engagement. Through SCORE initiatives, students have the opportunity to learn from experts and ex- expand their academic experience. As this is the final session of this series, we would like to thank all of you for your participation and engagement throughout the pediatric dentistry webinars, and we hope these sessions have been insightful and beneficial. It's a great honor to welcome Prof. Donald today, a distinguished leader in pediatric dentistry and dental public health. We sincerely thank him for joining us and sharing his expertise. To introduce our speaker and guide us through the session, I would now like to hand over to my colleague Wafa.
Hi everyone. We're very pleased to welcome Professor Donald Kai, who will guide today's session and share his expertise and experience with us. So, Professor Donald is a professor and a loyal and Kai champion and board chair of oral health at the University of Washington School of Dentistry. He's board certified in pediatric dentistry and dental public health. His NIH funded research focuses on the causes of oral health inequities and addressing them through community-based interventions and evidence-based policies. He received the 2017 IDR Distinguished Scientist Award and was named Pediatric Dentist of the Year by the American Academy of Pediatric Dentistry in 2018. In 2025, he received the Presidential Early Career Award for Scientists and Engineers award from President Joe Biden and was elected Fellow of the American Association for the Advancement of Science. Dr. Donald is editor-in-chief emeritus of the International Journal of Pediatric Dentistry. He teaches public health and provides dental care as a staff pediatric dentist at the Otis Brown Children's Clinic in Seattle. I will now hand over the floor to Professor Donald. I thank you so much for joining us today, and the floor is yours. You're in mute, Professor.
Thank
Sorry.
you. Thank you so much, Wafa. I'm going to get my slides projected here.
Yeah,
And I want to thank the IDS for the invitation to speak about my research. And so, so today I'm going to talk a little bit about a project that we finished up in Alaska, focused on sugared fruit drinks. And so this is an example of a community-based socio-behavioral intervention that we conducted. And I'm going to walk you through the process of how we got to the intervention, and I'll actually also be able to share some findings today. So really excited to do this, and then I'll take questions at the end. No conflicts of interest. Okay, so 3 objectives today. So by the end of today's webinar, you should be able to describe the underlying causes of oral health inequities, why certain children have poor oral health, why others can enjoy a lifetime of good oral health. You should be able to describe what a socio-behavioral intervention is, and then explain the relevance of community-based interventions. And this is really a really key point, that when we're talking about social and behavioral interventions, that the community piece is essential. So how this project all started. So I'm a board certified pediatric dentist in the US, and you can see here on the map, this is a map of North America. We have the US. And so after I finished my pediatric dentistry training at the University of Iowa, I moved back to Seattle, which is in Washington State. And I began going up to Alaska in 2012, to be a dentist, to be a part-time pediatric dentist. So I would go up to Alaska, particularly the YK Delta part of Alaska, to provide dental care. So my research interests in Alaska actually started off with me providing dental care. It did not start off with me doing research. So this is a picture of a typical airport in the YK Delta. You can see here this is this is the tail end of a very small airplane. Back in 2012, when I was making trips to Alaska, we had to pack everything in with us. So you had to pack in all your food. You have to pack in all the clothes that you need for 2 weeks, as well as all the dental equipment that you would need for the entire trip. And you can see here in these bins, this is my food stash, as well as the clothes and all the things that you need for these 2 week long trips. This is a typical photo of springtime in the YK Delta. You can see here that it's very rural, very remote. This is actually all on permafrost, meaning that a couple feet down into the ground, the ground is frozen. And so you can see here there is a wooden boardwalk that individuals will use to walk from one place to the other. ATVs can also travel along these wooden boardwalks. And most of the communities, there are about 50 to 60 small communities in the YK Delta. They have some common characteristics. So most of the communities have a clinic. So this building to the right is the local clinic. That's where local individuals will get their medical care and then their dental care when teams like ours will come into the community. Each community also typically has a small store. So you can't tell here, but the second building to the left, the turquoise colored building, is the store. And then very far into the background, you can see that there's a wooden walkway kind of behind that windmill type structure. And that walkway is the walkway over to the school. So in addition to that, most communities also have a post office, and the post office actually behind the person taking this photo here. And those are the common characteristics in terms of the types of services and buildings that exist in all of the communities. So when you're up in the YK Delta for 2 weeks at a time, you basically sleep wherever you can find space. So with this particular trip, I would make myself at home in the school library. So you can see here, there's a sleeping bag, and I have all of my belongings here, and this is what I would call home for 2 weeks. We would do most of our screenings in the school, and it just kind of depends on the community. Sometimes the screenings would happen at the clinic. A lot of times the screenings would happen at the school. And the reason why screenings at the school worked out really nicely is that all the kids are there. You're not depending on kids or parents or teachers to drive or get the kids over to the clinic. So you're able to screen efficiently. And here you can see here based on the equipment that we have here, we have our screening station. So this is where we would do the triaging. We would try to figure out among the 300 or 400 kids that are typically in a community, those kids that would need to be seen for treatment. Versus those kids that that seem to be okay, and we would get some fluoride varnish and betadine on their teeth. And so you can see a couple of assistants here painting fluoride varnish onto teeth. So oral health inequities, what are those? So oral health inequities, simply put, are health differences affecting disadvantaged groups. And that disadvantage is caused by unfavorable factors such as social factors, economic factors, or political conditions. So examples of subgroups that experience oral health inequities here in the US as well as abroad may be based on race or ethnicity, may be based on income. So if you're lower income, if you live in a low income home or a low income community, you're at greater risk for inequities. Disability status. We know that individuals with disabilities are at increased risk for health inequities, and we can see here that the graphs these graphs really demonstrate a really good case study on inequities. So we can see here if we look at the upper uh, uh, bars that the red bar is the percentage of children between the ages of 3 and 5. So these are preschool age children who have any untreated tooth decay. And we can see here that rate is about 10%. So the red bar up at the top, untreated decay, about 10% of all US children between the ages of 3 and 5 have a cavity, an untreated cavity in their tooth. Now, the blue bar is what we call Healthy People 2030. That's our Healthy People 2030 goal. So the blue bar is that by the year 2030, the goal is to have about 8% of children between the ages of 3 and 5 to have untreated tooth decay. So we want to move from 10% to about 8%. And you can see here that the bars are pretty close together. And so maybe there's some possibility that we can meet this national goal by 2030. Now, when you look at the green bar is the percentage of American Indian and Alaska Native children who have untreated decay. And we can see here that that's almost 75%. So what these bars demonstrate is oral health inequity. So the prevalence of untreated tooth decay is many times higher among Indigenous children in the U.S. Compared to non-Indigenous children, and this is an example of an inequity. So why is this? And we'll go into that in just a moment. But I think one of the things as dental students, as dentists, one of the things I think that we all recognize in dentistry is what happens when we have inequities. And this is an example. And actually, this is an example from one of the trips I took to Alaska, where children as young as 15 or 16 months are having to have their front four primary incisors removed because of extreme tooth decay. And you can see here that while this is an extreme example, it's not uncommon in lower income communities. And when you think about the communities that you will be returning to as dentists, this is probably actually pretty common worldwide. Now, what is it that causes inequities? And so we have a lot of different models out there that tell us, okay, what are the factors that cause inequities? What are the factors that cause this? And why this is important, why these inputs are important, is that if we know what causes inequities, there's some chance that we can do something about the inequities. We can intervene on these inputs. And we can see here, this is a model put together by colleagues at UCSF in San Francisco. Dr. Fisher Owens and team put together a multi-level model looking at all the different influences and inputs to oral health at the child, family, community, and environmental level. So lots of different factors here. And what this model, what it really recognizes and acknowledges is that the causes of tooth decay go beyond the three-circle model that we typically learn about in dentistry, that you have to have a host and teeth, microflora, and substrate, and that those three circles here are what comprise the inputs to oral health. But we know that it's more complicated than that. Now, one of the factors that comes from not just this model, but from our clinical experience, is that we know that sugar causes tooth decay, and sugar obviously is enters the mouth or gets onto the teeth behaviorally. So we can see here, this was actually a photo of our youngest Arctic at his 1 year birthday party. We can see here there's a cake, and so sugar is a behavior. Sugar intake is a behavior. Sugar is also can also enter the mouth socially. So we can see here, these are photos of grocery stores in Alaska, and we can see here there are large containers of these sugary drinks, these sugared fruit drinks. And if you're a parent like I am, many of you may be parents, you go to the local store, and if you're in this environment where you're surrounded by sugary drinks, unhealthy beverages, you can see how this might influence your purchasing decisions. So, based on my clinical observations providing dental care in Alaska, as well as other underserved communities here in the lower 48, what we call the continental US, is that we know that there are unresolved challenges in dentistry, not just in the US, but globally. And really, our goal is to look for solutions or related knowledge gaps in the literature, so that we can either implement solutions or generate knowledge to address knowledge gaps that will then lead to solutions. And what I observed as a dentist, as a pediatric dentist in Alaska, is that we really didn't know how to address the sugar problem, the high intake of sugar. And really, so the goal of my research, and this is something that happened over time in Alaska Native communities, is that I started recognizing that sugared fruit drinks were the cause of dental disease in Alaska Native communities. So we needed to go and get some research funding to address the knowledge gaps because the literature largely had very little insight on how we can address sugar intake in low-income communities. And so part of the science is generating hypotheses and coming up with potential solutions. So we did a whole bunch of pre-intervention activities. So this is up until now, this is all just me as a pediatric dentist making observations that there is a lot of dental disease, looking for potential reasons why, and noticing in the scientific literature that there really wasn't a whole lot in terms of solutions. So this leads us to pre-intervention activities. So one of the things that I worked on was putting together a conceptual model for Alaska Native communities as to what the inputs to oral health are in Alaska Native communities. And this is the model that really helped me and the team that I worked with to put our intervention together. So again, recognizing that the risk factors for dental disease and inequities exist at multiple levels, and that if you have some desire to want to eliminate inequities in oral health, that you need to intervene at these various levels. And how you intervene is going to depend on the resources that you have, the research partners and the community partners that you have, and what you're able to put together in the time frame that you have. So we did some pilot work in Alaska, and this is where we found collaborators at the University of Alaska Fairbanks who had developed a way to measure sugar intake through hair. And what we wanted to do with our pilot study was to assess, first of all, with Alaska Native communities, how acceptable is hair collection through a study? And then is there a way that we could measure sugar intake with the hair that was collected? And what we found, this was one of our first studies in the YK Delta, is yes, we were able to collect hair from children. There were no barriers to hair collection. And what we found was that children on average were consuming about 50 teaspoons of sugar per day, which is about the amount of sugar that you would find in 5 cans of US 12 ounces of Coca-Cola. So lots of sugar. And most of the most of the sugar was actually found in fruit drinks, and they were consumed at home. So this is starting to give us an idea of what a study might look like. You know, we're able to identify, yes, sugar is a problem. Yes, it can be measured through hair. You know, participants are willing to donate or provide a piece of hair to measure sugar intake. And then we also have an idea of where the sugar is coming from, in this case, the sugared fruit drinks that are popular in Alaska Native communities, and that most of it's being consumed at home. So when we think about behaviors, we know that behaviors are rooted in a variety of factors, including history, economics, and parenting. So when we talk to parents about these sugared fruit drinks, many parents talk to us about how they grew up with them. I grew up with Kool-Aid. They also talked about the economics, these sugared fruit drinks being inexpensive, but also easily accessible. Recall that grocery store photo of how easily accessible these powdered drinks are. They don't spoil. They can be stored within the house and kept for a long time, and they're easy to make. And then the parenting piece is that, you know, parents talk to us about how they allow their kids to make health decisions. This is not unlike a lot of non-Alaska Native communities where children are empowered to make some of the dietary decisions that they make. Social determinants of health are also important. So we have the behaviors, but also the social determinants of health. And SDHs are defined by the World Health Organization by the conditions in which we're born, in which we grow, live, and work, and age. And these are the conditions that influence both health status and health outcomes. So when we look at this photo that we saw just a moment ago of a typical grocery store in the YK Delta, we can see here that this social determinant of health, the way that grocery stores provide lots of unhealthy options can influence parents in terms of what they buy for their families and for their children. So simply, we're going to go through what a socio-behavioral intervention then is. So we recognize that diseases are caused by behaviors, and in this case, cavities are caused by excess added sugar intake. And then we know that behaviors can either be constrained or reinforced by the social context. So in this case, added sugar through fruit drinks is the behavior, and we have the store environment that reinforces sugar intake for children and families. So, socio-behavioral intervention simply is an intervention that focuses both on a particular or specific behavior and a particular social context. So that was the kind of the background. So the design of the study. So I mentioned at the very beginning the importance of community when it comes to socio-behavioral interventions. There's a very widely accepted approach called community-based participatory research, or CBPR. And this is really based on the premise that communities have answers. So, it's very easy for dentists, for professionals, for university-based people to go into impoverished communities and say, you know what, I'm well read, I know the literature, I've gone to school for a long time, I can see the problems. And I know the solutions. And this is the historical approach, right? Is that university-based researchers will go into communities and not really understand anything other than seeing the problems and then putting together solutions. And CBPR is a little different. CBPR is based on the idea that communities obviously are experiencing these health challenges that we're talking about, and in this case, unresolved tooth decay. And it's also based on the idea that because they experience these as individuals and as communities, these problems, they also have answers. And it's based on, CBPR is based on the idea of self-determination. So it's based on trust and mutual accountability. This is where researchers and communities will put together community-driven projects that have meaningful outcomes for everyone, not just the researcher. So CBPR-based approaches do tend to take a little bit longer than the traditional approach of just going in and putting together an intervention. And so it involves meeting with families, sometimes many, many times over the course of years to develop that trust so that university-based researchers and communities can work together. So based on our community planning meetings, what we found is that caregivers, they knew how much sugar was in things like soda pop. So they knew how much, sugar was in things like pop and carbonated beverages, but they were not as aware of the amount of sugar found in fruit drinks. Now, this isn't surprising given the marketing that companies will engage in when it comes to how they sell fruit drinks at the store. There oftentimes are pictures of fresh fruit. On the labeling, they'll advertise the drink is high in vitamin C. So it's not too surprising that a parent might think that these beverages are healthy. And I can't tell you how many times, when our oldest child was young and I'd go to the grocery store knowing that I'd have to come back with some kind of juice, that I would come back with just a horrible option just based on what I was able to see on the outside labeling without looking carefully at the nutritional labeling. We also know that caregivers give children large volumes of these drinks, and sometimes, young children have complete independence in terms of being able to access these drinks at home. Now, what we also found was that sugar-free drinks that parents, deemed them acceptable if they knew about them and they had a place to buy them locally. So this is where we're starting to get at an alternative of what is it that's possible that we can replace these sugary drinks with. So this is where we started working with community health workers. These are local indigenous community health workers from our target communities, where we could start training community health workers to actually deliver the intervention. And this was a very intentional step. We did not want to make it seem like, researchers were coming in and trying to change behaviors. We wanted to really take advantage of local voices and local individuals to help guide the process of behavior change. And so this is a photo of our training, or one of our trainings, one of our many trainings that took place in Bethel, which is the regional hub of the YK Delta. At this time, what we discovered is that in Seattle, these sugar-free drinks were starting to show up on the shelves. And so what these are is that they're called water enhancers. They contain artificial sweeteners, so no sugar. They're sweet and they taste like these flavors. So these are the flavors that we focused on for the intervention. And now, if you were to go to any U.S. grocery store and maybe even abroad, you can find dozens of different kinds of flavors of these water enhancers that don't contain sugar. We wanted to do some formal taste testing to make sure that children would be okay with the taste, especially based on the idea that parents reported back that they don't drink diet soda. So diet soda is not popular in the YK Delta. In fact, if you are in one of the grocery stores, you typically can't find diet soda. Now, when we gave some of these sugar-free drinks to the parents, they did say, yes, these taste good. My children will like them. But we wanted to make sure with the kids that the kids would enjoy them. So we did some taste tests. And what we found is that there was no significant difference in preference for the sugared version versus the sugar-free version for all four flavors that we tested. And in fact, if there was a preference, the preference was slightly in favor of the sugar-free drink. So we can see here, this is a photo of the different flavors as well as the sugared versus sugar-free versions, which we randomize and then use to test taste preferences. So this is really how we started putting our socio-behavioral intervention together. So back to this idea that parents did not know how much sugar was in fruit drinks, there needed to be a health education component. We needed to educate parents about how unhealthy fruit drinks that they were giving their kids, how unhealthy these drinks were. We also anticipated that children being children, that there might be resistance. So, here you have a child who for many years may be used to the sugared version of tropical punch Kool-Aid, anticipating that if you switch that out and started giving the child sugar-free fruit punch, there might be some resistance. So what we call self-efficacy training, this is the behavioral piece where we wanted to work with parents to help them anticipate what the barriers to behavior change might be, and then start thinking about ways that they might address these barriers ahead of time so that when it happened real time, parents were able to respond and they were prepared. And then the third piece here is the red circle is working with the stores to make sure that families would have a sugar-free alternative or these sugar-free drinks available locally in the main store. So the program took place over the course of 6 months. It was the equivalent of about 3.5 hours of contact time. And it involved 5 sessions and 4 check-ins. So sessions 1 and 2 were health education and then introducing families to sugar-free fruit drinks, teaching them actually how to mix the drink, actually practicing mixing the drink with the kids and then trying the drinks and really equipping the family with all the things that they would need to make the change at home. Sessions 3 through 5 focused on self-efficacy coaching and social support. So this is where our community health worker would work with families to try to identify ahead of time where their kids might show resistance and how they can get over or overcome that resistance. And then we had brief check-ins where community health workers would continue problem solving and remain engaged with the families to let the families know that they weren't alone, that this is a challenge that they'd be working on together. And then we made the sugar-free fruit drinks available at the local stores with vouchers. So we gave families some samples to start with, and then vouchers so that they could go to the store. And this is based on just simple supply and demand. We wanted to make sure that parents could rely on the stores to, over time, go to the stores to get these drinks, so that when the study's over, after the study's over, you prime the pump and you teach the parents and the families that yes, if you want to give your kids the sugar-free drinks, they can go to the store and you can get them there. These are little snapshots from session one, which was about 40 minutes long, and this was an interactive whiteboard video. So this is whiteboard videos are those videos that we showed on iPads where there's a hand and the whole education is being drawn out and explained verbally at the same time. And the kids really liked it. The families really loved it. The whiteboard videos were just fantastic. And this is a photo of one of the communities in terms of where they put out the sugar-free drinks for the families to purchase. So the study focused on UPIC children between the ages of 1 and 11 in YK Delta, in Alaska's YK Delta. Our outcome was a hair-based biomarker, which was measured from baseline to 6 months. And the high biomarker briefly is based on a carbon-nitrogen isotope ratio in the hair. And the great thing is this biomarker actually can be collected through hair, blood, urine, fingernail. It's collected through a variety of different biological tissues. And at the time, we focused on hair. This was a non-randomized parallel assignment, two-arm superiority trial with unequal allocation. So we had three communities, two communities, the children got the intervention from baseline to 6 months, and then the control community was a delayed treatment control. So they got the intervention after the main study period, and we used a regression with imputation. So in terms of the final touches of the intervention, so in October 2019 is when we pilot tested the intervention, and we had everything ready to go in January of 2020. And many of you will recall what happened just a few months later in March 2020 with the global pandemic. And so the intervention was postponed, and we were able to launch 2 years later in September 20 of 22. Uh, During those 2 years, we did have to pivot. So, we had the intervention planned, in a particular way, but because of COVID, we had to make some changes. So we went from 5 community health workers to 2 community health workers. The program was originally home-based, where the community health worker would visit families in the home, but because of social distancing, we ended up having to revert to the clinic. So families had to come out to the clinic to enroll and participate in the intervention visits as well as the data collection visits. Lots of different things going on because of COVID with masking and social distancing, lots of illnesses and cancellations because of COVID. And it was quite the challenge, I think, in terms of delivering the intervention as planned to some communities and some families because of what was happening with COVID in the background. And there were certainly some changes to the data collection protocol, including having to remove some of the data collection pieces just because it was so time intensive. So one example of this is that we had 24-hour recalls originally planned at each data collection visit. And what we found is that the 24-hour recalls would take anywhere from 15 minutes to an hour per child to collect. And this is where a staff person, would sit down and go through everything the caregiver had given their child to eat and drink the last 3 days. And as you can imagine, that's a pretty intense data collection endeavor. And maybe if you're a family with one child enrolled in the study, maybe that's something you can tolerate and get through. We had some families that had 5 or 6 kids enroll, and it almost became just impossible to collect all these data in the time period that we had. So in terms of results, so we ended up enrolling about 201 children, and we had 6 month data for about 62% of those kids, so about 124. What we found was that median sugar intake at baseline was about 147 grams per day, so a little bit less than our pilot study in in Bethel that we did. Not super surprising given that these kids were a little bit younger. For the pilot study, we had kids all the way up to age 17, so not too surprising there. And what we found is that the mean marginal change increased significantly for all children, regardless of which arm, whether that's intervention arm or control arm. Everyone's sugar intake increased. And so in the end, what we found was that, across the three communities, so community A and B were the intervention communities, community C was the delayed treatment control community. The p-value was zero point 0.7, so there was actually no significant difference between the two intervention communities and the control community. Now you can see here, statistical significance aside, there was a tendency in communities A and B, which were the intervention communities, where the mean marginal increase wasn't as high. So, 15.8 and 10.9 is a little bit lower than 16.2. So there may be or may have been some slight intervention effects here, but again, statistically significant, they were not. So looking back here, lots of different lessons learned, and I realize I have probably about another maybe 3 or 4 minutes here. So we'll go over lots of different lessons learned. I mean, I think that this was a tumultuous time for all of us. I mean, whether it be for communities in Alaska or my own community here in Seattle. So lots of different things happening. So I think lesson number one is that in science, things don't always work out the way you think they will. I think especially with community-based research, you're constantly having to pivot. And our major pivot with our study was a global pandemic. And so having to modify protocols, having to just kind of change things up as needed, was kind of the name of the game throughout the process. The great thing is, I think lesson two is that we gain strength from the communities. I think that there's a perception that impoverished communities that there aren't resources and that they're not necessarily good sources of strength. And I have to tell you that all the time leading up to when the intervention actually occurred, throughout the intervention, and then afterwards, when we went back to the communities to share our findings, to help interpret some of our findings, what I found was just the tremendous amount of strength that I myself personally, as well as our research team, got from the communities as well as families. And it was just absolutely remarkable, just how strong these families and communities are. Lesson number three is we got to the end. I think there were lots of moments throughout the study and especially during that 2 years in between when we were ready to launch and when we actually did launch about whether the study was going to happen. There were multiple points at which, there was the possibility of us losing our grant funding. COVID spikes would happen, lots of different things were happening. So at any given day, things could have just ended, but we got to the end. And the great thing is, I think that regardless of our, statistically insignificant findings, we've learned enough really to build on what we've learned and consider the end a new beginning. So we can continue to do work, because obviously the clinical challenges and the health challenges, are still there. Lesson number four is that science funding is not linear. So for those of you who are interested in going into science, sometimes, you listen to a presentation like this, and it just seems like, oh, well, you just go apply for funding, you get it, you do your study, you publish, and then that's the end. And that's not necessarily the case. So we can see here, this is a brief history of funding of how we ended up getting the millions of dollars that we needed for this study. And it really all started with a pilot grant back in 2013, a local pilot grant to do that hair study that I mentioned at the very start. And that pilot study also took, a year and a half to get. So here we are, the funding for this, project started back in 2013, and the subsequent grant that we got, was not until many years later, and then the study finally ended in 2024. So this whole process is taking a really, really long time. And I think the take-home message here is that, that if you keep at it, that funding is available. It's out there. Sometimes you just have to keep trying. And lesson number five, I think, we all know what's happening in the US with our science enterprise. It's an absolute mess. And unfortunately, the U.S. is not alone. I think what's happening in the U.S. Is happening in many other locations globally, with governments deciding that they're going to invest less in research and health research. And I think this all is, I think, a reminder to us all of how important it is now more than ever to continue doing good science and consider doing more in whatever capacity we each can. And I think that the science is going to be important, not just to move the fields that we're working in forward, but that communities are also looking to us for solutions that we can help contribute to. So really important to continue doing science. And to continue, trying to get research funding, doing what science you can with local sources of funding, to get to solutions. With that, I'd like to acknowledge a large group of collaborators and community members. This was an enormous undertaking, funded by multiple NIH grants as well as local funding sources. And with that, I'd like to thank everyone. This is my email address and my LinkedIn URL. Please stay in touch. And with that, I'll stop sharing and I'll take any questions. Thank you.
Thank you so much, Professor, for this very insightful and engaging session. We truly appreciate the time that you taken to share your expertise and the valuable knowledge you have provided us today. We will now move to the Q&A session. So please, anyone, if you have any question, please feel free to share them in the chat. I'll start myself with a question, if you don't mind.
Not at all.
So, Professor, were there any aspects like of the intervention that you had adapted based on community feedback during the implementation? Like, would there had there been any adaptation according to their feedback?
Yeah, Wafa, that's a really good question. So I didn't go over this, but one of the really great features of our study, so we had a delayed treatment control group. So this is where communities A and B got the intervention at baseline, and then community C got nothing. They got no intervention at baseline. But after that main period, they then got their delayed intervention. Because there was some time between when the intervention communities got the program and when the control group got their program, we were actually able to do some rapid qualitative analyses with the intervention communities to modify the intervention that the control arm families got. So we were actually able to make quite a few adaptations. So one of the adaptations, and actually this was one of, I think, the sources of maybe why there were some null findings, was the store component. Again, remember that the context here is COVID. I mean, there's just chaos everywhere, right? I mean, supply
Yeah,
chain problems, all that stuff. So one of the issues that families reported to us afterwards was that they weren't able to get drinks from the stores. They weren't able to get the sugar-free drinks at the stores. So, so here it is. They learned about these sugar-free drinks. They learned how to make them. They got a whole bunch of samples. Their kids like them. The kids are asking for them. At first they were able to get them through the store, but then the store, either for whatever reason, they didn't put them out. They were put behind the counter. Families couldn't find them. And so families couldn't actually access the sugar-free drinks. And that's going to be a problem, right, with this type of intervention. So what we did for the control families was that we actually gave them, so we talked to the intervention families. We were like, okay, so assuming that if we had to fix this, how would we fix this? And so some of the families talked about how they were able to get their own. So they went to Anchorage, they went to the capital of Alaska on shopping trips, or they ordered it through online. So they were able to get these sugar-free drinks. But one of the things that families talked to us about was, hey, what can you just give the families the entire supply at the beginning? so that they don't have to worry about the store component. And so we did that for the control group, is that we modified that. There were some other modifications, but yes, I think that's a really good question. And I think it's so important to get feedback from families when you can so that you can try to improve the program to meet local, circumstances. When we put the intervention together, remember, it was also, probably, a couple of years before it was actually implemented because we had that 2-year period in between and things change. And so we were able to make some modifications, at least for the families in the control arm.
Great. Yeah, of course. That makes sense. We have another question that says, what structural policy changes do you think would have a greater long-term impact than individual level intervention alone and reducing early childhood caries? Yeah.
Yeah, that's a really great question. So again, my training is in public health. I'm a pediatric dentist, but my training is in public health. This is, I think, where policies are so important. If you want to have the most impact on the most number of families and individuals, policies, I think, are going to be the most important. So an example of policies here in the U.S might be, we have what's called the SNAP program. So this is the Supplemental Nutrition Assistance Program. So this is a food program for low-income families where they get a card to buy food for the families. So historically, families were able to purchase sugary drinks, sugary foods, unhealthy foods with these what we call food stamps in the U.S. And what we've seen recently, particularly this year, is that states have been given the freedom to restrict purchasing on these food stamps for these with these food stamps. So each state may have different rules, but some states have actually removed sugar-free drinks. I'm sorry, sugar-sweetened beverages from being able to purchase those. So will this have an effect? I think so. I mean, we'll have to do the evaluations. And I know that there's a lot of debate over whether or not restricting purchasing is the right thing to do, whether it's ethical. And I think we can have those conversations and we need to have those conversations. But I think in terms of purchasing behaviors, we know that when you restrict behaviors, when you implement sugar sweetened beverage taxes, for instance, that consumption goes down, that intake goes down. And presumably, if sugar intake goes down, it should have an effect on caries rates.
Okay. Yeah. Perfect. Thank you, Doctor, for your answer. There's another question that says, what would need to change to adapt this intervention for urban population or other marginalistic groups globally?
Yeah, that's a really great question. And our group has thought about this. I think these sugar-free drinks are a feasible solution in many different settings, whether it be, urban or rural, outside the US. I think that, it's important to make sure whatever target population that you're looking at or a population of interest, that you do the proper pre-intervention work to make sure that these drinks are acceptable. There's a lot of concern out there about artificial sweeteners, and I think that these concerns are largely unfounded, especially with the amounts of intake that we're talking about with children. But those things need to be taken into consideration. If you have a family or a community that is absolutely against artificially sweetened beverages, then this intervention probably would not work. Because the families would say no, we don't do sugar free. So you would want to do that. So I think this is the importance or why it's so important to make sure that you're working with communities, that you're working with families that are representative of the types of families that you hope to influence with your intervention. And then it's really about working with families and the communities to figure out how it is, how is it that you get these healthier drinks into the hands of parents? So is it direct distribution? Do you give these out in clinic? Do you have a home visitor, a home health visitor deliver these during home health visits? Do you offer it through the stores? It's going to depend. And I think this is what makes it challenging. But this is also what makes it really fun is that, that you can work with communities to tailor the intervention specifically to your community of interest.
Yeah, I agree. Thank you so much, Professor, for the wonderful webinar. It was very insightful and well organized, and we really learned a lot. I learned a lot because I'm a public health student, and it was a great deal from you. So thank you so much for this webinar, and we're hoping to see you in our next series. And thank you everyone for attending.
Thanks for having me.
Of course, our pleasure. Please, everyone, scan this code and give us your feedback.
Wonderful. Well, thank you so much. This was a lot of fun. Okay, I'm gonna head to my next meeting. Thank you.